All right. I would like to welcome everyone to our Sharp community conversations on heart attack and heart failure in women and what to look out for and ways to prevent heart disease. I'm Natalie Haverluck, and I am a board member for the San Diego division of the American Heart Association, as well as the Senior Director for Drug Discovery and Early Development at Edgewise Therapeutics. I am excited to have you all here today to join us in this engaging panel discussion on something we all deeply believe in at the American Heart Association, and I know Sharp Healthcare also does. And that is bringing awareness to heart attacks and heart failure in women and discussing the ways to prevent heart disease. One reason I am also excited to be the moderator of today's panel is because I am a heart disease survivor. I've always lived a healthy lifestyle with heart disease prevalent in both my and my husband's family, and we always made healthy eating and regular exercise a top priority. I'm an avid runner, and I've been a member of the Brooks ID racing team. I had numerous races, running distances from 5Ks to marathons. However, after collapsing upon one of my half marathons back in May of 2009, I was told that I had a heart issue. This was a shock to my family and friends because you can believe that they knew me as one of the most healthiest people, and they could not believe that I actually had something wrong with my heart. Over the years, I'd always felt that something was not quite with my heart, but I always dismissed it because, I was young and healthy, and I just attributed that to stress because I was always that person who ran around trying to do everything all at once, giving my 110%. Thankfully, I had friends who knew me very well and knew some amazing cardiologists. And they were all very quick to figure out that I had right ventricular outflow tachycardia. I still recall the shock I had when the cardiologist looked at me and said, "We can just go in and fix it." I was stunned, and I still remember that day very vividly when I looked at them and I said, "Are you serious? You're going to go in and fix my heart?" But once again, I was very grateful to have these wonderful physicians, and I knew they could fix my heart. And so back in February 2010, which coincidentally is Heart Month, the doctors went in and they fixed my heart. As you know, with any type of heart surgery, the recovery was a long and slow one, but with the support of all my wonderful friends and family, I was able to get back to running. And that August in 2010, my friends formed a Heart Walk team for me. Along with the American Heart Association. And since then, I've made it a mission to promote heart health and to support other women in understanding their risks and bringing awareness so they can live their lives to the fullest. So without further ado, it is my pleasure to introduce to you our panelists for today's conversations. Dr. Joanne Gomez Arnold, who is a board-certified physician in cardiovascular disease affiliated with Sharp Rees-Steely and Sharp Memorial Hospital. She has expertise in echocardiography and nuclear cardiac imaging. She also has advanced training in women's cardiovascular disease, including conditions such as cardiac microvascular disease, myocardial infarction without obstructive coronary arteries, and peripardium cardiomyopathy. I'd also like to introduce Dr. Marin Nishimura, who is also a board-certified physician in cardiovascular disease and internal medicine. She practices with San Diego Cardiac Center and is affiliated with Sharp Grossmont Hospital and is part of the Sharp Grossmont Hospital's Women Cardiovascular Program. She has particular interest in issues specific to women's cardiovascular health, including management of pregnancy-associated cardiovascular diseases, spontaneous coronary artery dissections, also known as SCAD, and heart failure with preserved ejection fraction, known as HFpEF. I'd like to take a few minutes now to highlight some of the missions of the American Heart Association and the research that they do to support the cruciality of this topic. The American Heart Association has a mission to be a relentless force for a world of longer and healthier lives. They are able to do this with experts and volunteers across the globe to achieve this through a focus on the areas shown here, where they are able to raise awareness through community education and preventive initiatives, and be able to optimize prevention and critical care. They support research, they engage communities. They also have a huge involvement in advocacy, and they're able to monitor the progress. They've made great strides in raising awareness, educating women, and providing programs and resources to those who need it most. But we must continue to do more as heart disease continues to claim the lives of women. Over 18 years ago, the American Heart Association launched Go Red for Women to bring awareness that heart disease is the #1 killer of women, and that women are often misdiagnosed and unaware of that lifestyle changes can make and help prevent heart disease. That is why we are so grateful for those who come alongside with us, like Sharp Healthcare, in supporting the conversations as we work to break down the barriers to help bring health equity rights here to San Diego. So when we talk about heart disease, we ask, what is heart disease? Heart disease is a simple term that we use to describe the various types of problems that are related to the heart. And we can use cardiovascular disease as an interchangeable term with heart disease. So this is a disease that involves the heart or the blood vessels, the arteries and the veins. And you've heard people discuss things as blood clots or cholesterol plaques, or the heart muscles such as the atrium or the ventricle. Many people, though, use the term as heart disease or cardiovascular disease or coronary heart disease, which is just one type of heart disease. Cardiovascular disease can refer to many types of conditions, such as a heart attack, heart failure, an arrhythmia, heart valve problem, or even stroke. So why is this important to women? And one thing that women are not aware of is that 44% of women that heart disease, cardiovascular disease, is the leading cause. We talk about this all the time. It's #1, and we don't want to be #1. 44% of women ages 20 or older are living with some sort of cardiovascular disease that I just mentioned on the previous slide. And this remains to be the leading cause of death in women. Women experience unique life stages. These are pregnancy and menopause, and that puts them at a increased risk for cardiovascular disease, yet continue to be underrepresented in cardiovascular research. When we compare this health data from women to men, one may lead to the conclusion that men's health is the gold standard and women's health is atypical. This overlooks the unique biology and the life stages of women that impact their health. So how do we prevent cardiovascular disease in women? The American Heart Association has identified the 8 most important factors for cardiovascular health. 4 of them are health behaviors and 4 of them are health factors. The 4 key health behaviors are shown here: stopping smoking or vaping, getting enough sleep, having a healthy diet, and increasing your physical exercise. When we look at the key health factors, those are blood pressure, your blood lipids, your healthy weight, and your blood sugar. And we'll go into this along with Dr. Nishimura further on in the presentation. So now I would like to hand it over to Dr. Nishimura.
All right, thank you for the warm introduction and thank you for having me here today. So my name is Dr. Marin Nishimura. I'm a practicing cardiologist at San Diego Cardiac Center, and I work at Sharp Grossmont Hospital as well. And I'll be talking to you about heart attack in women. Next slide. Okay, so why is it important? So cardiovascular disease is the leading cause of death worldwide, as we talked about already. And although it's commonly thought of as a men's disease, it affects both genders alike. And I think we touched on some of the statistics, but I think it's important to reiterate. So 1 out of 3 women die of heart disease, and it kills approximately the same number of women as all forms of cancer, chronic lung disease, and diabetes combined. But unfortunately, there's still lack of awareness of heart disease in women. And this is also unfortunately true among healthcare workers as well. And because of this lack of knowledge or misunderstanding that women are at relatively lower risk of heart disease, that could then lead to less women being refer to cardiology when it's clinically indicated. Women are also less likely to be referred for invasive procedures, even when they're clinically indicated, and so forth and so forth. Also, they might be doing less screening measures when they're seeing primary care doctors. So that's why these, outreach and educational opportunities like this, led by American Heart Association and Gold Red for Women, is very important, so that we can spread the awareness of heart disease among women, so that women could be championed for their own health. Next slide. So what is a heart attack? So going back to the anatomy, heart is essentially a hollow ball of muscle, and it has to have its own blood supply. And as you can see in the slide, there are blood vessels that deliver nutrient-rich blood to the parts of the heart, and it delivers nutrients and oxygens. And in heart attack, what happens is that, the blood vessel, for one reason or another, gets blocked off so that the nutrient doesn't reach the part of the heart, and therefore the heart can, or the part of the heart can no longer function well. And if the blockage is not opened in a timely fashion, then that part could be, irreversibly damaged. Irreversibly damaged. And what happens with the heart attack diagnosis when you go to the hospital? So what do we do? So we look at the exam, vital signs, and there are other important tests that we do also to diagnose heart attack. The things that we do, the first thing is EKG, or electrocardiogram, and you've seen those, red squiggly lines, and we can tell if you're having acute heart attack, but sometimes it doesn't even show. So even if the EKG is completely normal, that doesn't mean you're not having a heart attack. That's just one thing. The another important thing is a blood test. So the heart muscles, cells have these particular protein or enzyme called troponin, and each part of the cell in our body, it has different roles, and therefore it has different proteins or different things that they have in their cells. And the heart muscles specifically have this thing called troponin, and when it's damaged, so when the blood flow is diminished and the heart muscle is injured, the membranes or the cells become more permeable, or in the simpler case, simple terminology, it gets injured and it lyses open. And what's inside the cell could then be detected in the blood cell. And that's what we do when we're in the emergency room and trying to diagnose heart attack. And that's called troponin. And if it's positive, then it's possible that you're having a heart attack. Nowadays, the tests are really, really good. So if this test is negative, a couple of times after the onset of symptom, we can pretty effectively rule out heart attack, but that's not to say it's not possible. So we do have a condition called unstable angina, where even though you're essentially having heart attack for all other intents and purposes, but for some reason blood test is negative. So it's not impossible to have heart attack without positive markers, but it's still possible. But that's another important thing that we do. Also, if we have time, we might do a test called echocardiogram, which is an ultrasound of the heart. So we look at the heart visually to see if it's squeezing well. If there's a heart attack, then a part of heart might not be moving as well. So that tells us, yes, this chest pain is likely coming from a heart attack. And the gold standard diagnosis is called coronary angiogram. So that's an invasive procedure where we will go in from the artery in the wrist right here or in the groin, and we go into the heart, and then we inject contrast dyes into the blood vessel to visually look to see if there's a clot. And if there's a clot, then we put in a stent, which is a metal straw to essentially open up the blood vessel. I get this question a lot. Do we take out the stent? No, we do not. It stays with you forever. If there's lots of blockages, then we might refer you to a cardiothoracic surgeon to do bypass surgery. And I think, yeah, that's it for this slide. So next slide, please. Okay, so we've all seen movies where, a middle-aged man gasps and clutches at the chest and falls to the ground. And that's what we think of when we think about heart attack. But obviously, heart attack could as equally happen in women. And also it might not be as dramatic or as obvious as the ones that's seen in the movies. So the typical symptoms are chest pain, but women are likely to have more atypical symptoms. So what are the atypical symptoms that they might have? Symptoms include things like nausea, vomiting, shortness of breath. They might also have pain in the belly region, the upper belly, not exactly the chest. They might have pain in the jaw, shoulder, and also extreme fatigue is another one too. And one important thing that you could have heart attack without ever having chest pain, is particularly in women, particularly if you have diabetes too. So those things are kind of make it particularly challenging to diagnose heart attack, especially in women. And because it's atypical symptoms, women may chalk up some of the symptoms to less life-threatening things like acid reflux or the flu or just aging, and that could be detrimental. So knowing that women are at risk of heart disease, if you have any of those symptoms or concerning symptoms, right thing to do is to go to the emergency room and seek out medical attention. Next slide. Okay, so there are risk factors for heart disease, and there are risk factors that are both relevant to both men and women, obviously, and there are some that are only specific to women that are of particular interest in this talk as well. So on the left side are the traditional risk factors, and things include diabetes, and that also includes whether or not it's well controlled. If the diabetes is poorly controlled, you're at higher risk of heart disease. If it's better controlled, then your risk will be lower. Smoking, it's never too late to quit smoking. Smoking definitely increases your risk of cardiovascular disease. Obesity does too. Physical inactivity definitely also ties into weight as well, but overall, higher risk of heart disease. High blood pressure, and whether or not, not just the diagnosis, but as I talked about in diabetes as well, the control of it is important too. If your chronically blood pressure is top numbers in 160s, as opposed to your well-controlled top number in 120s, obviously your risk of heart disease is going to be different. And then the cholesterol, also pay attention to the 3 numbers. I think we're going to talk about it later in the talk. But yeah, those are the risk factors that's common in both men and women. And on the right side are the specific risk factors that's relevant in women. And these are also in the guidelines too. So when you see a primary care doctor or cardiologist and if you have any symptoms or not, and you're trying to figure out your risk of heart disease, you should definitely bring these up to your doctors as well for accurate risk stratification. So the women-specific factors that could increase your risk of heart disease, one is a preterm delivery. Another one is a hypertensive disorders of pregnancy. So if you have preeclampsia or eclampsia, also gestational diabetes. And the top 3, the disorders of pregnancy, we kind of consider pregnancy as a stress test for women. So if you're developing these abnormalities during pregnancy, then you're essentially failing the stress test. So you're at higher risk of coronary disease in the future. So these should, raise some red flags to make sure that you're continue to follow up with the doctor to make sure you're minimizing all the risk factors, so that you can make sure you don't develop heart disease in the future. Other risk factors are autoimmune disease like lupus and rheumatoid arthritis. Those are more common in women. Breast cancer treatment, some therapy could increase your risk of heart disease like doxorubicin. And radiation in the chest area also increases your risk of coronary disease as well. And mental health, very prevalent in women as well. And controlling mental illnesses also improves your heart outcome. So these are all very important risk factors, but make sure to know about the one on the right that's specifically relevant to our women. Next slide. Okay, so far we talked about, the typical heart attack, the blockage in the blood vessel that happens from the clot, but there are some special types of heart attack that affects women in particular. So those are the coronary dissection, microvascular angina, and broken heart syndrome. So we'll talk about that next. Next slide. So coronary dissection is a very interesting condition where the block in the blood vessel happens from a tear in the blood vessel, in the inner lining of the blood vessel. So there's no clot, there's no plaque, and it is responsible for 35% of the heart attacks in women 50 or under. And the classic presentation is women that are pregnant or early after pregnancy or delivery, and they present with chest pain just like heart attack, and they are found to have this. And in fact, I actually had a patient with this case very recently, try not to give too much detail, obviously, but middle age, minimal risk factors, look like heart attack for, just heart attack otherwise. So, blood test, EKG, echocardiogram, and symptoms, everything pointed to heart attack. But when we do the coronary angiogram, it shows no plaque, no blood clot, but there is that tear in the blood vessel causing the blockage. The therapy for this is medical therapy, so non-conservative management. But then another important thing to note is if you're diagnosed with this, you need to scan, we say head to pelvis. So CT head, CT neck, CT chest, and CT abdomen pelvis to look for any other vascular abnormalities, because conditions such as fibromuscular dysplasia could predispose you to dissection. Okay, next slide. All right, and microvascular angina. So this is a type of angina, so chest pain that's caused by problems in the small vessels of the coronary arteries. So, and it is more common in women than men, and majority happens in the postmenopausal women. And it happens in women with diabetes, high blood pressure, and those who smoke. And when you do the coronary angiogram, so these patients will have essentially the same classic symptoms, chest pain with exertion, shortness of breath. And when you do the coronary angiogram, though, the main vessels that we look at, the main vessels that we worry about, it might not have any big blockages, and it might be not as exciting for the people that are doing the procedure. However, the telltale sign is that the tiny blood vessels at the end, the microcirculation you can see in the figure, it will show slow, sluggish flow. And that's the hint that her I'm assuming it's her symptoms are secondary to microvascular angina. And, it might not be from a big blood vessel. So sometimes these women, they might fall through the, medical care and not get the follow-up that they need. But these women, even though they might not have the big blockage, they still need aggressive high blood pressure control, aggressive cholesterol management, making sure the diabetes is controlled, and staying away from smoking. All these things are very, very important, because as studies have shown that women that have this condition, or people that have this condition, they are at higher risk of having future heart attack and future heart disease compared to regular population, even though the big blood vessels are not affected. Okay, next slide. And finally, so broken heart syndrome. This one is also known as Takotsubo syndrome, and 90% is reported in women between ages of 58 and 75. And symptoms, again, identical to heart attack. So chest pain, shortness of breath, and this tends to happen after severe emotional stress. That's why it's called broken heart syndrome. And again, the blood test, the EKG, the echo, they're all going to look like heart attack. It's going to look like a major heart attack as well. But when we do the angiogram, it will show no blockages. Fortunately, the prognosis for broken heart syndrome is very good. So we start medication, and on follow-up, after a couple months, we repeat the echocardiogram, and it will show that the heart function has recovered. So that's a good prognosis, but still a very, very major, very serious presentation. And we need to do the angiogram to rule that out. And this happens more common in women, especially postmenopausal women. And that's it for my part for now. Next slide, please.
All right. Good evening, everyone. I'm Dr. Gomez Arnold, and thank you for the introduction earlier. Let's go ahead and talk about heart failure in women. So this is the next part of the talk. Thank you for allowing me to be part of this talk. I'm very honored to be one of your panelists today. So what is heart failure? We know this sounds really severe and really bad, but let's talk about the basics. What is this disease process, right? So this is a lifelong condition wherein the heart muscle, so the heart is a muscle, when it could not pump enough blood to meet the body's needs, and the body needs oxygen and also needs blood. So looking at the images here, on the left side of the heart, of the left side of the picture is the normal heart. So I wanted to bring you to how blood flows through this heart, right? So the purple part of this is deoxygenated blood. So the blood actually goes from the rest of the body to the right side of the heart here, from top, and then goes to the bottom. And then it goes to the lungs. Once it gets the oxygen from there, it goes to the left side of the heart, where we see this area where there's red blood, because it's oxygenated, and then it goes to aorta, the main conduit of blood to the rest of the body. And so, as you can see here, the most muscular, or the thickest part here, is the left lower chamber. That's the left ventricle. That's the part of the heart that is the main pump. So in heart failure, we actually, going to the picture here on the right, as you can see, in a type of heart failure, there's actually thinner, bigger, left side of the heart. That is because it's a weakened heart muscle. When that happens, it is less efficient as a pump, and it cannot supply the needs of the body. When the heart cannot keep up with the workload, that is what we call heart failure. And there are several types, and it's also very prevalent. As a matter of fact, 1 in 5 Americans will develop heart failure in their lifetimes. Next slide, please. All right, as I mentioned, the heart is a muscle. So how it presents, how it feels like, what the problem with the heart is, also goes as to the muscular property of the heart. So we'll talk a little bit more about the different kinds later on. Next slide, please. There's several causes and risk factors for heart failure. Some of them are actually overlapping with risk factors for heart disease or heart blockage, but particularly for heart failure, let's go through them. One is diabetes. Similarly, uncontrolled diabetes is actually going to be a worse prognosis for heart failure. Obesity or higher weight or weight gain, particularly central or what we call visceral obesity, the type of weight gain that is from the central part of the stomach is higher, is a worse prognostic factor for heart failure. Also, history of myocardial infarction or heart attack or heart blockages, what we call coronary artery disease, what we just reviewed earlier. The downstream implications of those kinds of diseases, ultimately, if there's a heart blockage and there's impaired blood flow, that can actually weaken the heart muscle acutely, meaning instantaneously in an event or even with time. So that's very important. Also, congenital heart defects of the heart when we are born. Some people have abnormal holes in their heart or abnormal connections in their heart that predispose different areas of the heart to different pressures and different loads that could also lead to weakening of the heart down the line. High blood pressure is a big one, particularly, well, in both men and women, but women are actually known to have, in a way, thickening response to high afterload or high pressure workload from the heart. So that's very important in developing heart failure, both the type of heart failure where your heart pump is weak or when it's still not weak. Also, abnormal heart rhythms can also weaken the heart, especially if they're uncontrolled or you're having fast heart rhythms, such as atrial fibrillation or atrial flutter. All right, next slide. So what are the symptoms of heart failure? There is actually a very wide variety of symptoms, and every person is a little different. But generally speaking, the main one probably is fatigue. So in the first picture here, fatigue, shortness of breath. Looking at the second picture here, there's also a tendency for fluid overload or excess fluid. So the picture here actually indicates swelling in the legs. That's also a very big one. So let's go back to what I mentioned earlier. Since the heart is a muscle, if the muscle and the heart is not pumping the right way, it tends to back up. And where does it back up? It backs up to the lung, it could back up to the belly, it could back up to the legs. When it backs up to the lung, that could cause lots of shortness of breath. Sometimes people can't even lay down now because they kind of feel like they're drowning. That's one symptom of a more advanced form of heart failure. Sometimes people feel like their belly is getting bigger. They're accumulating some fluid in there, or their legs are now puffy or swollen. Now they're taking their socks off at the end of the day and they're creating marks. And that's a new symptom. They didn't really have that before. They're more fatigued. That's also a symptom of heart failure. And also in more severe cases, sometimes people can get dizzy with standing. That's also something to take note of. Next slide, please. Let's talk about some terms that we use generally when we talk about heart failure, which is ejection fraction. So what it is it's the amount of blood pumped out over, so it's a fraction, over the amount of blood that is in the chamber. So what it is in other words, it compares the amount of blood that is in the heart compared to the amount that it's able to pump out. So the more efficient the heart is in being a pump, the higher the ejection fraction. So this percentage helps us determine how well the heart is doing in supplying blood flow to the rest of the body. And that brings us to the next slide here, which is what are the different kinds of heart failure is primarily determined by this this concept of ejection fraction. So the first in the green area here is normal ejection fraction, usually within 50 to 70%. So we generally do not have 100% ejection fraction, because normal ejection fraction, a little bit different with men and women. They say women actually, the limit of normal is actually higher, but in general, a number of 50 to 70% is normal. That is 50 to 70% of the blood that goes in the heart is pumped out. Usually patients who have this kind of ejection fraction have normal activities. They're very comfortable. The second category is people have borderline ejection fraction, meaning it's low, 41 to 49%, but not severely low. Sometimes in these patients, they could have symptoms when they are doing more activities. And we go to the third category, which is patients who have a reduced ejection fraction, generally less than or equal to 40%. That means with each contraction, there's less amount of blood circulating in the body, and people can have symptoms even sometimes at rest. Of note, there's also the normal ejection fraction is not necessarily completely normal in all patients. Sometimes people have what we call heart failure with preserved ejection fraction, wherein even if the number or the pumping function is normal, the heart is stiff. And that could still be a heart failure, a different kind of heart failure, even if their heart function or ejection fraction is more than 50%. And we'll talk a little bit more about that later. Next slide, please. So there are several differences with heart failure in women versus men. They say statistically, fewer men experience heart failure than men. However, as we know, women actually have a slightly longer lifespan than men. As such, we've actually been seeing that women have been representing a growing proportion of heart failure. As a matter of fact, currently, women account for around 50 to 55% of the prevalent heart failure cases. Risk factors are slightly different in men versus women, while there's lots of overlap. But in terms of the most significant risk factor for women, it's actually high blood pressure, hypertension that we talked about. Usually that is blood pressure more than 130 or 80. That's persistent. For men, it's actually ischemic heart disease, which is the heart disease from heart blockages. Ischemia is a term we use to describe heart diseases from decreased blood flow. So usually from heart blockages, heart plaques. Overall, while women have better survival rate than men in heart failure, trending this with time, we actually found that heart failure survival is slightly improving with time, but more in men than women. So that also kind of begs the question, why is there better improvement in survival in men than women? And that probably alludes to the need of more outreach and more advocacy for treatment of also women with heart failure. And in the future, it's actually predicted that women more than 65 years old will become the largest proportion of patients with heart failure. So this is certainly a big problem, and certainly recognizing is number one, and also prevention. So we'll get to that too. Next slide, please. So there's special types of heart failure in women. So far, we talked about the whole spectrum. The heart failure with reduced ejection fraction, where the heart pump is weak, is both prevalent in men and women. But in terms of heart failure that is more common in women or only noted in women, we'll specify and talk about those a little bit more. So first is heart failure with preserved ejection fraction. Those patients with ineffective pumps, well, even if their heart ejection fraction is more than 50%, that's one. And second, patients who have peripartum cardiomyopathy, which is cardiomyopathy, heart failure surrounding pregnancy, either new onset during pregnancy or even afterwards. So let's talk about that. Next slide, please. So for heart failure with preserved ejection fraction, we know that women are twice more likely to develop and experience a greater symptom burden with this kind of heart failure. Usually there's some inconsistent symptoms or atypical symptoms. Not only do we find that in chest pains, as we talked about earlier, but even in heart failure. These could lead to delayed diagnosis and treatment. In general, women, well, universally, we can have, when we have heart failure, there could be weight gain, fatigue, shortness of breath, leg swelling. Those symptoms sometimes could be less predominant or less aggressive on the start. So they could be more subtle. So that could also lead to delayed diagnosis. I showed you earlier the image of the heart, and if you remember that image, in heart failure, the bottom part of the heart is connected to the left upper chamber of the heart. And if there's lots of backflow, that upper chamber of the heart can actually dilate. And that links to and predisposes people to atrial fibrillation. Now, that atrial fibrillation is an electrical problem of the heart where there's multiple areas at the top chamber of the heart that are superseding and increasing the heart rate. When patients have heart failure with atrial fibrillation, that actually together, that further increases the risk for cardiovascular disease. Women exhibit also worse quality of life after diagnosis of heart failure, and actually are more prone to developing depression from this heart disease. Of course, when you have this entity or are suspected to have this, you should certainly see your cardiologist. Your primary care doctor would also be a very good resource at this point. The main cornerstones of management would be making sure the pump is actually, we're helping the pump beat forward. And so we want to control the blood pressure so there's less load for the heart to pump against. We also can use sometimes water pills or medications to help you pee the excess fluid from that buildup. And also, if for some patients who do develop atrial fibrillation or abnormal heart rhythm problems, concomitant treatment of that would be very important. Next slide, please. Let's shift gears into peripartum cardiomyopathy. It's, as I mentioned, it's a form of heart failure that develops during pregnancy or postpartum. The incidence usually happens within the first 5 months of pregnancy if it does develop postpartum. It occurs in around 1 in 3,000 deliveries, so it's not that uncommon, really. It occurs more in African American women, for women more than 30 years of age, or for patients who actually have other risk factors during that pregnancy. For example, having high blood pressure during pregnancy. Also, patients who have pregnancies that are multifetal, twin pregnancies, triplet pregnancies, that actually increases the risk of this entity as well. The good news about peripartum cardiomyopathy, it's actually some recovery is actually expected. A majority of patients do demonstrate partial or even complete recovery within the first 2 to 6 months. However, that's not everyone. As a matter of fact, we sub-stratify patients that we see in clinic if they have this entity, if they have residual heart dysfunction or not. Both of them are at increased risk in succeeding pregnancies, but certainly a higher risk of cardiovascular events if their heart function does not recover after the 6-month time period. There's also a risk of recurrence for subsequent pregnancies. As a matter of fact, that would be around 1 in 5 pregnancies. Let's say your heart function recovered after that episode of peripartum cardiomyopathy, compared to another person whose heart function never recovered. That risk is actually developing it again in 1 out of 2 subsequent pregnancies, certainly higher. So as such, it's also very important for patients who have this to be very carefully monitored, not only during pregnancy, but also after pregnancy, usually by a multidisciplinary team, OB, cardiology, if needed. And touching a little bit of why this is the case of, the pathophysiology of peripartum cardiomyopathy, the exact mechanism is still elusive. This is still a big area of research. But currently, the leading hypothesis is it could be a 2-hit hypothesis, wherein there's a genetic predisposition, that's one. And the second is there's a vascular insult. For example, a hormone, prolactin, is implicated in developing this. Currently, we're actually looking into their studies that are underway to look at how this can be prevented through hormone blockers, but the results of that are not available yet. So we'll have to see. But currently, there's no particular targeted therapy for peripartum cardiomyopathy apart from how we treat cardiomyopathy and heart failure in general and close follow-up. Next slide, please. All right, so with that, let's go ahead with our section on keeping your heart healthy and our preventive tools. Let me forward you to Dr. Nishimura.
All right, so we talked about heart attack and heart failure, but how can we prevent this? And the easiest way to prevent, or the best way to prevent it, is to follow Life's Essential 8. So this is developed by American Heart Association, and it has 8 very important components that you can keep in mind to prevent development heart disease. And prevention is definitely easier than managing conditions that has once developed. Next slide, please. So the important thing is healthy diet. So diet that's rich in fruits and vegetables. What I usually tell my patients is, something that has to be sustainable. And I actually so in my current practice, I happened to replace another doctor who was who would recommend veganism to all the patients that had a heart attack. And they will often get really turned off by it. They'll leave. And then a couple of years later, they'll come back and see me. And I tell them, no, that's not that, it has to be a sustainable thing. It's something that you can do and you can keep on doing. Because if you're, turned off by something that's very, very, that's not possible, then there's no point in that. So what I recommend is something sustainable that you can keep up with. So try to incorporate some, obviously more fruits and veggies. And in terms of protein, try to do skinless poultry, so chicken, turkey, and try to incorporate some like olive oil instead of butter, some easy things. Try to convert full sugar soda to diet soda. Try to limit things, but not completely take it away. And I don't know if Dr. Gomez believes in this, but I'm a big believer in cheat days as well. I can't live without cheat days. So we obviously want you to be healthy, but we want you to be healthy and have fun too. So obviously healthier lifestyle, definitely a big component of, preventing heart disease, but something sustainable, something feasible. Next slide, please. Okay, and being more active. So inactivity is just really not good for you. So recommendation is 30 minutes of exercise 5 days a week, but that's the goal. You don't have to start running a marathon. What I recommend is walking counts. Start by 10 minutes, make it 20, make it 30 over time. Start it twice a week and then slowly increase it to 5 times a week. And there are some weeks that you can't do it, but that's okay too. Another thing specifically for women is the muscle strengthening activity. And we often forget about this, but this is very important for, bone density and also strength overall. So incorporating that too. And even after heart attacks, exercise is very important. So, physical inactivity after heart attack has been shown to lead to worse outcome. So I definitely encourage even heart attack survivors immediately after that to try to increase activity as they're able. And I enroll them in a very good program called cardiac rehabilitation, where you can do exercises with nurses and healthcare providers and other heart attack survivors too. So you can get other support that way, but it's a very comprehensive support mechanism to incorporate exercise early in your recovery. Next slide, please. Okay, and stopping smoking, definitely something we have to mention every single time. So it is the most preventable cause of death in the United States, and it's linked to 1/3 of all deaths from heart disease. And not just a heart attack, but there's this other condition called peripheral vascular disease, which is a disease of the leg vessels. And I personally have never seen patients that have that do not smoke. So it's that toxic to your blood vessels. And also another new thing in the Life's Essential 8 that was incorporated is that the e-cigarettes and vapes are now incorporated, and secondhand smoke as well are now identified to be risk factors as well. So definitely make sure to stay away from vaping. That's not a better replacement for cigarettes. Definitely not good. E-cigarettes, and then and encourage your family members to stop smoking too, because secondhand smoke has been linked to heart disease, and that's in the guidelines now. Okay, next slide. I think this one might be Dr. Gomez.
Yep. So sleep. So sleep is certainly very important. Currently, the guidelines say, an average of 7 to 9 hours is important. And for kids, actually, probably longer than that. Poor sleep has been noted to put you at risk for several things, particularly heart disease, but not only that, more than that. So that would be putting you at risk for cognitive decline or early dementia, or even depression, high blood pressure, obesity, all these things. So making sure that you're able to incorporate a good sleep at the end of the day, that would be very important for your heart health, decreasing the stress of your body. Next slide, please. Let's talk about your weight as well. Currently, we know that 145 million Americans are overweight or obese. One measure we look at is body mass index. It's actually a numerical value. You can Google kind of a calculator and put your height and your weight in there. It'll give you a value. I won't bore you with the math, but I can if you want. But basically, an optimal BMI is 25. 18.5 to 25 is normal. More than that is overweight or obese. And actually, at that point, above the optimal BMI of 25, your risk of cardiovascular disease actually increases. So it's going to be important to get this under control. And through measures such as what Dr. Nishimura mentioned earlier too, physical activity, incorporating that, and also sustainable dietary changes. Next slide, please. And let's know our numbers. So the last 3 of this 8 essentials would be involving numbers: your blood pressure, your cholesterol levels, your blood sugar. In terms of your blood pressure, so there's 2 numbers. A lot of you know this. The top number is the systolic number, and the bottom is the diastolic. Generally, perfect blood pressure, 120/80. We usually say more than 130/80. And if it's sustained, would be a threshold for you to tell your primary care doctor if you need further management for that. In terms of your cholesterol, this usually involves a bigger panel, but the main ones to keep an eye on would be HDL, high density lipoprotein, also called your good cholesterol, and the LDL, which is the low density lipoprotein, which is your bad cholesterol. We certainly have different limits or goals of how high or low your cholesterol should be, especially depending on what your risk factors are. So generally, we want to keep that LDL low. And your blood sugar. This is in the realm of also preventing or knowing if you have diabetes earlier than later. A fasting blood glucose. So the numbers would be a less than 100 milligrams per deciliter would be normal. Between 100 to 125 is pre-diabetes, and 126 or greater is diabetes, usually type 2 diabetes. So knowing these numbers, being your own personal advocate, and working with your doctors is going to be key for making sure you have a good health going forward. Next slide, please. All right, and these are our resources of the things we have talked about. And for more details as well, you can reach out and go to the resources supplied by the American Heart Association here. All right, it's time for questions.
All right, well, thank you both Dr. Nishimura and Dr. Gomez-Arnold for giving us some wonderful information on keeping our hearts healthy. And for those of you who wanted the links and the resources to those web pages, they're in the chat box, and we'll also be sending them up in a follow-up email. So if you'd like to post any questions, please post them in the chat box and we'll get to them. And we do have some questions for both Dr. Nishimura and Dr. Gomez-Arnold. So we will start with one here. The question is, my LDL is at 225. I have a family history of heart disease. What signs should I be aware of? I know that heart attacks and strokes are sometimes hard to diagnose in women, and I want to know if and when I should be going to the ER.
Okay, so yeah, I'll take this question then. So thanks for the question. So the LDL was over 200, correct? Now, I agree that's a very high risk, and especially with the family history too. So those are some very red flags, in my opinion, when I see a patient with very high LDL, and I consider that greater than 190 very high, and family history of heart attack at young age, 40s, 50s, in the first degree relative, mom, dad, or brother or sister, that's big red flags. If that's the case, I definitely have to recommend starting a high intensity statin. So statins, it has a bad rep in the media, but it is a really great medication and it saves lives and it makes patients live longer. So I'm a big supporter of that. Not all statins are created equal. So some are called high intensity statins. So those are the atorvastatin or Lipitor or Crestor or rosuvastatin in specific doses too. So you have to make sure that you're on the high dose. There are other ones too, like Zetia, other ones too, but it's not considered high intensity. And with the LDL level that high, you do need to be on high intensity statin. You also have to wonder whether or not you have this special condition called familial hyperlipidemia. So that is where there's a genetic abnormality. There's three major ones that leads to very, very high levels of LDL and early coronary disease. So those patients, they sometimes offer genetic testing as well. And if you're found to have that gene, make sure your LDL is controlled and it has to be less than 100 with high intensity statin. There are other medications that you can use on top of it too. Some are injections, costly, but insurance does cover it with diagnosis of familial hyperlipidemia. So that's why knowing the family history and the genetic testing even is important to get that coverage as well. And what are the symptoms? So yes, thank you for paying attention. There are the symptoms could be a little bit tricky in women, especially. So the things to worry for will be chest pain, shortness of breath, but other atypical symptoms. As I said, you could have a heart attack without chest pain too. And if you have a family history and LDL, any concerning symptoms, doctors won't fault you for coming to the ER. So any concern, go to the ER and make sure to get checked out. If it's not something, or if you're having it on and off, not acute issue, you can always get a referral to a cardiologist and they can do the further testing for you as well.
I certainly agree with all of that that Dr. Nishimura said. One thing I just also like to add is sometimes when we do have patients that have really extremely high cholesterols, like these more than 200s, one might kind of wonder, do you, at this point in time, do you already have heart blockage? Do you have evidence of heart blockage? And one other tool that we sometimes use in the world of cardiology is also a screening coronary CT score, calcium score. So we can do a low dose CT scan of your heart, just a quick look to see if there's evidence of heart plaque already at that level. So certainly those would be things for discussion with also your primary or your cardiologist, if that would be appropriate, because if you already have a heart plaque at this point, then certainly more reason for you to be on all these good medications.
All right, thank you both. Our next question is, at what age should the doctor start doing any health screenings? I am 58 years old and I haven't done any type of screening.
I can take this one. I would say there's no really too early age to start screening. It also, every person is different. What your risk factors are, that would be the biggest thing. I would say at this point, at 58, you are presumably in an early postmenopausal category. And that's also a time period in our women's lives that cardiovascular disease risk is increased. And so depending on your family history, your risk factors, high blood pressure, your sugars, your cholesterol, all that would be a good time right now to be screened through your primary care doctor. And should you have any symptoms, new shortness of breath, how much you're exercising is going down, you're having some either typical or atypical chest pains, also that would be a good time to see your doctor. But right now at this age would be a perfect time to get started on that.
And yeah, I'm echoing what Dr. Gomez said too. And also, the doctors are screening every time they see you with the blood pressure, so that they might not be necessarily directly screening for heart disease per se, but they're screening for risk factors of heart disease. So, they will check your blood pressure every time they see you, and they should be checking cholesterol panel too. Starting at age 20, every 4 or 6 years, to make sure that LDL and cholesterol is controlled. They should be checking for diabetes if you have risk factors. I think after age 40, every couple of years, every 3 years or so. So they are screening for risk factors and making sure you're not developing any of those before it becomes a heart disease. And then make sure that you mention, if you have any family members that develop heart attack at subsequent visit, to make sure that adds into the risk factors as well. And mentioning, any pregnancy complication that we talked about, like the preeclampsia, those things. Yep.
Thank you very much. Our next question is, I lost my mother to heart failure in 2021. We didn't recognize the signs, and she drove herself home from work, went to sleep, and stopped breathing. It was horrible and tragic. How can we raise awareness so other daughters don't have to go through this loss?
Yeah, I can answer this. So sorry to hear about this tragedy in the family, but certainly heart failure has a very bad prognosis. Early recognition and early treatment and being on the right medications. And now what we know from cardiology, the field is advancing so much that we actually are getting more and more tools to treat this. So I think making sure that you are seen also with this family history, having a screening also. It sounds like this is sudden death, sudden heart attack, or noted later to become heart failure. But judging by that, also if they're younger and this is a sudden event, screening of the first degree relatives for cardiomyopathy or heart failure, as some of these could be genetically driven, would be helpful at this time too. And I think in terms of advocating and making sure that, no one, we can prevent this in the future. I think all of you guys that are here, it's really great to know that you guys are here, because all of you guys are our allies. We're not just sending this message to just you, but we know that you knowing what the signs and symptoms are and getting the word out there is going to be important, so that we know and we're able to treat this sooner than later and prevent these things in the future.
All right, we have time for a few more questions. We have a question here from the chat. Should your primary care physician be screening us for partial blockages? How do you get the screening before you have symptoms? And I believe we may have already touched a little bit on that, but I don't know if you would like to add a little more to that.
Yeah, so I can tackle this one too. So the asymptomatic screening, I think you're talking about like maybe like stress tests and stuff like that. We don't necessarily recommend it for patients that are asymptomatic. And the reason why is because if we did stress tests for everybody, especially patients that are at low risk, younger patients that have no family history or other risk factors like high blood pressure, diabetes, if we screen everybody, we're going to get high rate of false positivity, and that's not really helpful. So we do selective screening when they start developing symptoms. So that's why, the primary care physician hasn't started screening you specifically, for heart disease with something like stress tests. But obviously, as we kind of touched on earlier, they're screening for risk factors. Also, I think Dr. Gomez talked about this too. If you have lots of risk factors, let's say family history, mother, heart attack, 40s with cholesterol, and your cholesterol number is somewhere in the middle and you're not really sure what to do, we do have this thing called CT with calcium scoring, which is a relatively new thing where they do a quick CT and look at the calcification that's in the blood vessel. So we talked about the plaque, and plaque becomes calcified most of the time. And so we can see how much calcification is in the major blood vessels. And if you have enough calcification, then even if the cholesterol is not too bad, you're young and otherwise don't meet indication to start statin or aspirin, that will give you the push to start statin and aspirin even before you start developing symptoms. And those tests, we do that for asymptomatic patients. Sometimes we get difficulty with insurance coverage, and I think it's about $100, $200 out of pocket, and you can just show up and do it too. So yeah, calcium scoring is very useful, especially in those intermediate risk patients, especially if you're concerned about risk factors.
All right. Well, thank you very much, Dr. Nishimura and Dr. Gomez-Arnold, for answering all the questions. And thank you all for submitting your fantastic questions. And unfortunately, we will not have time to answer all of them, but we will follow them up and continue in script on the conclusion of the webinar. So we would like to move on and continue on our opportunity drawing that we had this evening. And so we would like to announce the winners. I hope I'm not mispronouncing your name, but our winners are Janelle Woody-Wiss and Judy Stevenson. So congratulations to you both. The AHA team will follow up with you, both of you, via email. So congratulations. And I would also like to thank Dr. Nishimura and Dr. Gomez-Arnold again for joining us today and sharing your expertise and knowledge. We are very grateful for you both as being leaders and strong voices in our community and advocating for the patients as well as our community wellness. And I would like to thank everyone who joined us today. And we hope that you're leaving feeling inspired with new ideas on how you can create healthier lifestyles and choices, and that we hope that you can share this information with all the what you've learned today with other women on cardiovascular health. We'd like to let you know that you should receive a recording of this conversation with a follow-up email. And once again, we'd like to thank all of you, along with the panelists, for joining us today. And we'd also like to give out a special thank you to our community conversation sponsor, Sharp Healthcare. So with that, we'd like to wish you all a good evening and thank you all once again.